Planning and Oversight Committee meeting for September 2nd. Have a roll call, please.
Mr. Albright.
Here.
Mr. Arnold.
Here.
Ms. Banks. Ms. Bell. Present. Ms. Carter. Ms. Clark. Here. Dr. Elhide. Here. Ms. Freeman. Kevin Gordon. Here. Ms. Powell. Here. Mr. Miller. Ms. Mendoza Locke. Here. Ms. Rodriguez. Mr. Salas.
Here.
Major White. Here.
All right, we have recognition of visitors, please. All the Public Council, St. Paul Community Center, and
Tina Layson, board chair.
Hey, thank you. Welcome. All right, I'm assuming everyone has had a chance to review the minutes for the August 5th meeting. Your motion?
So move.
Second?
Second.
Any questions?
No.
All right,
It's gonna be that kind of meeting.
those in favor?
Aye.
Those against? Any abstaining?
Abstain.
Motion passes. Thank you. Moving on to our first item on the agenda, which is item number 5. Not necessarily first item, but item number 5, which is the financial update. We're gonna ask Jenny to make her presentation.
This is just a quick update to let you all know where we stand with fiscal year 25, which ended in June. It's substantially completed. We have a couple things we're wrapping up. We just started finding out today, some of our carryover requests from MHRSB, if they've been approved or not. And we're still wrapping up some of the streamlined payments because we want to make sure, since the system is new, that we're capturing everything. And we have a couple of Danny's Place invoices that have been trailing, we're trying to capture too. So rather than provide incomplete information, we're gonna do it next month.
No, there's no motion on this, it's just an update, explaining why financials weren't being presented today.
Thank you. Any questions for Jenny? Hearing none, moving on to item 6, the MHRSB addiction treatment program allocation. Elijah, please.
Good afternoon. This is some information for the addiction treatment program. This is funding we received from the state of Ohio to support individuals who are enrolled in a certified drug court with a substance use disorder to pay for treatment and recovery services as they are moving through recovery and working with the court. We have approval for some carryover from last fiscal year, which will be added to the allocation of $250,000. So again, individuals in this program have a substance use disorder and they are enrolled in the adult drug or family drug. MHRSB allows us some administrative funding for the agencies who participate with clients. So at the bottom, you'll see kind of the breakdown of how this funding goes. So the Lucas County Common Pleas Courts, which administers the adult drug court, there's some funding for the administrative expenses and then funding to reimburse for recovery supports. So think of things like, some housing, helping people obtain identification, maybe things to help them with transportation or employment. Those kind of recovery supports are reimbursable. The Lucas County Juvenile Court, they work with TASC there, so they get some administrative expenses, and then TASC Northwest Ohio also gets some of that, and then funding to help with recovery supports with family drug court. That court's a little smaller than adult drug court, which you'll see the difference, which accounts for the disparity there. Then Ohio Guidestone, Harbor, New Concepts, Unison, and Zeph all participate with their clients who are involved in the drug court, and we're allowed to authorize some administrative expenses there. You'll see these varying amounts for administrative expenses. Those are based on how many clients each agency had participating in the drug court. So the formula we use is really based on if you had more clients, then you receive more in administrative expenses versus if you only had a couple clients, you received less in administrative expenses. And then we have a set aside to go towards our purchase of service. So that's the treatment allocation we give for those individuals who are uninsured or underinsured and Lucas County residents meeting income guidelines. So at the beginning at the bottom, page 9 up to 10 is the motion, just accepting the new allocation and authorizing the additional amount we're receiving from Ohio MHRSB to allow for a pool of funding to be created and agreements to be established with the entities involved in this for fiscal year 26.
Motion.
Second.
Properly motion and second. Any questions?
No, you answered our questions by your thorough explanation. Thank you very much.
I do have one question. Again, thank you for the formula, because that was a question that I had. Now, is there a schedule for that formula? I mean, up to?
It's just kind of, we use the numbers from this year to kind of project for next year. So it's kind of on like a per client, how many clients each person had in the drug court for that last fiscal year.
So if I looked at this, I would assume that Unison and Zeph had frankly around about the same numbers, or which was I'm looking for is a range. Was there a range?
I think it's an amount per client. Calculate.
Are you asking, what is the variable for
That's
each
correct.
client?
That's correct.
So basically, we take the whole administrative amount that Ohio MHRSB tells us is for this grant, and then we say, okay, this agency had this many clients, this had this many, and then proportionalize it.
So it's the same amount for each agent. Each client, the variable is the number of clients per agency.
Any additional questions?
Just New Concepts as a new name or?
No, it's Filio New Concepts. They always do business as.
Oh, got it,
Other
okay,
legal names.
okay, cause I've seen it like both ways and I'm like, just making sure it wasn't donation, thanks on that, was a question I think from.
Any questions? Those in favor?
Aye.
Any opposed? Any abstentions?
Abstain.
Roll call.
No, this was-
All in favor?
Aye.
Opposed? Motion passes. All right. You know, this is my first time doing this, guys.
Everybody just have a deja vu moment.
You're doing great.
Very good, thank you. We're moving on to item 7, Lucas County Common Pleas Court, juvenile division report, Elijah.
Yeah, so you'll remember back in December, we brought a request to provide some funding to the Juvenile Detention Center to support youth who are currently in detention because of the increasing mental health and behavioral health issues detention is seeing. So over the past few months, we've been working with the detention center to kind of identify a long-term plan. And they've arrived at one through some consultation with us, but they've been kind of proactively looking at what best provider for them to work with to move forward. So they want to provide a robust mix of behavioral health services for those youth in detention. And so they'll be contracting with Unison Health to do that. Unison Health will be providing things like assessment, crisis intervention, medication management, some therapy, some specific SUD treatment for youth in detention. And they've already started to do some of this work. In fact, they've even worked at by building a closer relationship with COBACR, which is the inpatient psych unit for kids who need that level of care to kind of help facilitate kids moving there. They've been successful with that over the past couple of months. So we're recommending a total allocation of $100,000 for this fiscal year to begin July 1st through the end of June 2026 to support Juvenile Detention Center and their work of meeting those needs of the youth in detention. So happy to answer any questions about that.
Do they follow up with the kids when they're released?
Yes.
How many kids are typically in juvenile division that may be needing this type of support? Do you have any kind of metrics or numbers on that?
So their average daily census is 37, but today they have 41 youth, and at any time one of those youth might need some crisis intervention by Unison to kind of de-escalate.
Is it safe to assume that these funds would be payers of last resort? In other words, they don't have private, the juveniles don't have private insurance, or there's not some other available source to cover the assessment and treatment care?
Yes, so while they're in detention, they want to have access to another payer.
And if they're still youth and like,
Yeah.
I guess even if their parents still have,
Yeah, I know it sounds weird. We have been exploring how agencies can bill and there's been state talk around the state on how to do that. There's just not a way to do it.
sure.
So even though they have, I just wanna make sure I'm trucking along here. So if my child is in the one is insurance, my insurance won't cover. Now, as long as they're in-
Same with adults. If you're in custody, you're in custody to the court that has put you behind bars.
Little known fact, I bet.
And sometimes that also applies to the state hospital system.
Revelation. To be honest, it really is for me. I did not realize that.
I obviously didn't either.
Do the parents have to sign a release for the juvenile to get this treatment?
At some point they do, but for some of them more immediate needs, if they're on detention and they're,
Good.
dysregulated, Unison will have to intervene and then, get releases on the back end for long-term treatment and medication.
And they consider youth 18 and under.
My question would be, now, the motion itself does not contain Unison. I know within the body of your discussion, you stated Unison. I'm assuming that this gives the authority to change the provider at any given time.
Yeah, we have left it to juvenile court to decide who they want to contract with.
This is maybe you may not know the answer to this question. So since these are juveniles and it's the state or the county's responsibility to provide the care, is it the state and county that's giving the consent for the juveniles to receive the care? I mean, who are the consent givers to the treatment?
I don't know the full answer to that question. They work with the parents for medications and things, but there might be some,
It still may be the parents. Okay, all right, thank you.
Or child protection services.
Oh, okay, all right, thank you.
Is there a motion to approve?
Second.
Second. Any additional questions?
I have one question. So do you foresee this being an ongoing line item every year?
potentially.
Yes. Just, I don't think Elijah mentioned it, but this used to be under the ZEF contract, Juvenile Detention Center. So we just moved it to the Lucas County Juvenile Court last January, and now this is a continuation.
Why? Because it seems like it would be more comprehensive if it was all.
Because, thank you for that question. Juvenile court and ZEF Center weren't able to work well together, and for various reasons. And nowhere else in our system do we give money to a entity and then tell them who to subcontract with. So we don't, or let me rephrase that. Nowhere else in our system do we fund an entity to work within another place. So we just followed our own I don't know, I wouldn't call it a rule, but our own practice of allowing the entity that is housing the facility, the provider to work with somebody of their choosing. And we get out of the middle of the contract then. And ZEF, just to be clear, ZEF and juvenile detention was a mutual separation. It wasn't a one or the other.
Questions? All right, those in favor?
Aye.
Opposition? Abstention? Motion passes. Moving on to, we do item 8, Ohio Miles State Opioid and Stimulant Response 4.0 0-year 2 grant. That's a lot.
So you may recall last year, the state decided to do more of a competitive bidding process for the state opiate and stimulus response grant. They opened it up to all boards and individual behavioral health entities to apply directly to them for funding. So in that, we encouraged all of our providers to submit their own application, and we submitted one as well. Our application contained two priority things. Our full application contained three things, but with the funding we got, we focused up on two of them. This is year 2 of that. So we didn't have to reapply for it. It's a continuation. So this motion looks very similar to the one last year because it's just an extension. So for our allocation from the state, we recommend that this goes to our purchase of service allocation for the treatment of individuals with an opiate use disorder or a stimulant use disorder. And then you'll see at the bottom of page 10, those agencies that we would be applying that money to as billings come in, that criteria of opiate use disorder or stimulant use disorder. And then we would continue to fund the Mercy Mother-Child Dependency Program, which is outreach and case management for women who are pregnant and using opioids or stimulants to connect them with treatment services and make sure they're getting care and being ready for the delivery of their child. So those are kind of the 3 areas that we're recommending that this funding continue to go. And at the bottom, at the top and bottom of page 11, there's a series of motions to that effect.
The amount for,
Do you have any success numbers?
Regarding,
The folks who are receiving the grant, like Zeph Harbor, New Concepts, Unison, people receiving some of this grant money, are there any success?
so,
Metrics, success, anything?
So this-
They've gotten it for 1 year.
Yeah.
So have they?
so think of, so when we're applying it to POS, so similar how we just track POS spending. And then they have an additional requirement to do a federal GIFRA, which SAMHSA requires a lot of federal funding, which is goes over the national outcome measures. This is an assessment they do at the beginning of treatment, at the like 6 months, and then after release. We get those numbers. They're very hard to understand. And sometimes because there's so many clients who may be touching a number of those GIFRA points. So while we might, for example, New Concepts also gets a significant amount of money through SOS to support some of their efforts. So they might be paying for staff to do, let's say, outreach to specific population with their SOS funds, and that would be a GIPRA. And then we might come in and pay for treatment services, which is the same GIPRA.
Got it.
And then, you know, if another agency, for example, might be using the SOS money to fund recovery housing, it's the same GIPRA.
So you're not really comparing apples to apples when you're
Yeah,
tracking?
yeah, so the state uses it to kind of give an overall county
Sure.
point of view, but how they decided to go about doing this really is difficult to say, you know, this program is successful versus this program.
Yeah.
Because it's kind of putting all these GIPRAs in, mixing them all up and doing some more macro level metrics.
I just think that sometimes it would be good to hear, beneficial, that the work that we're doing, is it working? Is it impactful? Are lives being changed? And what are those stories? What are metrics on those? How do we track success? That's all.
Item number 11. But I will say, and I don't think I'm misspeaking, the state was satisfied enough with our programming this year that they allowed us to go into a non-competitive process for next year where they're giving us the same amount of money.
Perfect.
Ready. Had a motion, is there a second?
Question. I'm top of page 11, I don't know if it matters, but it's the wording, second sentence, pregnant women who tested positive for opiates, doesn't mention stimulant in that sentence.
Yeah, the Mercy primarily works with opiates, and opiates. They're allowed to, with this funding, work with women who use stimulants, but that's not their target population. And that's historical with SOS. It only began as a response to the opiate epidemic, and then a few years ago, they added stimulants. That's why we still call it SOS, the state opioid. But yes, yeah, the Mercy's real focus is on women who are using opiates.
But they wouldn't turn away a woman that is using stimulants. I'm just wondering if that language can be added.
Yeah, in their marketing, they do.
Is there a second?
I'll second.
All right, any additional questions? All right, all those in favor?
Aye.
Those against? Any opposition? Motion passes. Move to item 9. Health Recovery Mental Health Recovery Services Board policy review. And we have Scott, it's gonna be doing that.
Thank you. I do want to address your question more directly before I move on. They would have the discretion of serving that patient or moving that to somebody else if they so chose that is more appropriate. The language in the motion allows them that flexibility. In the narrative, it doesn't need to say stimulants.
All right, thank you.
Okay, let me draw your attention to page 12 of the packet. I guess that's page 12 and page 13. Hopefully, this is the last policy you guys will have to review for a while. And all full disclosure, there is a question on if this should actually go to the executive and nominating committee and not to this group, but we're not planning on having an executive and nominating committee, so I would have had to hold you together specifically for the review of this policy, which made no sense at all. And I think you guys are flexible enough to allow me to present this instead. So we are.
Yes, and I thank you.
So this is one of those straggler policies that got away from us. And it's been a long time policy that quite frankly needed quite a bit of review. So it is a prohibition against the use of hazardous procedures in our research on human subjects. We've had a little bit of the conversation about this, not this direct policy, but the impacts of some of the things going on in our community around the use of AI and some other items that we integrated into this change. But specifically, we updated references to the MHRSB, not the board. We added prohibition to using therapies and procedures conducted by artificial intelligence. The thought of an avatar is actually doing that work, then that would be prohibited. The ability to use AI in the background for note taking and billing, things like that, that still is allowed. That's a business practice that isn't a treatment or a therapy that would be allowed, and it would and is being used in our system in various places. It eliminated the reference to OAC, Ohio Administrative Code, that were no longer valid. They were outdated references. It moved previously required notification language as it's rendered mute by the other sections of the policy, meaning the understanding is these things aren't allowed and we won't be contracting with you if you decide to do those. So there's no reason to tell us you're doing them because we don't have a contract with you. So it was kind of like a circular kind of discussion. We did specifically eliminate or delete from the policy ECT, which is electroconvulsive therapies, because the research has emerged enough now that it is a standard practice and there is policies and practices and research behind it that ECTs are actually being done in our community, not by our community mental health centers, but by our hospitals. And if we had left it in this policy, then we would not have been able to contract with hospitals for like the hospital access program. So we eliminated that. We replaced it, as I said, with artificial intelligence and psychedelic therapies we added in because that's an emerging practice. Now, that's on the bubble right now. Something like ketamine is being used in private practice for breaking through major depressive disorders and other things. They're seeing some promising practices, but we're not seeing that right now. And we've shut. I don't believe we're seeing that right now in private, in our public funded entities. It goes without saying, and it's covered by other policy of client rights and full disclosure. So it just wasn't necessarily within this policy. So those are the changes. There is a motion to approve that policy on the middle of page 12. I'm happy to answer any questions. Yes, sir.
So as far as emerging treatments and therapies, like psychedelics, right now we're prohibiting them, correct? So what is the benchmark? What organization or agency that says, hey, this works, or what would we use for you to come back to us and say, hey, just like you did the ECT, how that this is now is acceptable and being used and we should strike it. So what are we using for that benchmark?
So I'll tell you what I use around ECT, give you some benchmarks. We obviously do internet search. And we do dig down into the research to figure out, okay, is this commonly accepted now? We also, look at where is that practice emerging from? We know of private practices that started ECT, and then the hospitals have started to pick that up. So I know St. Charles is doing ECT. So I'm also looking at, okay, where in the medical system is that being done? I'm also taking feedback from our community mental health centers. What are they looking at? What are they doing now? ECT is very expensive to do. Our community mental health centers aren't going to do that. But theoretically, you could see them do ketamine. We would have a lot of questions around that. The other thing is I'm looking at other payer sources and what they're doing. It's my understanding that ketamine's being used off-label right now, which is why it's primarily in private practice. You don't see that in the public practice because it would get rejected by Medicaid as a non-standard practice because of the billing. Now, that's my assumption. I don't know that for sure. Maybe if there's a few people on this board that know a little bit more about that than I do, now's the time to speak up. Yeah.
So in other words,
Yeah.
you would do the
Yeah.
board would, staff would do the research and come back to us, hey, this is now a standard practice.
Yeah, there's ECT was an easy one because we hear about it quite a bit now. There's, I think, maybe 3 or 4 different ECT programs just in Lucas County alone. But these other ones, psychedelics, I brought up ketamine, but they're using LSD and other things like that. And, we have some biases toward that, obviously. But those biases aren't unlike what we saw in methadone when methadone first started out, or, buprenorphine or other things. So we're trying to remain open to the emerging practice, but cautious.
Out of curiosity, how do we police this if we're allocating funds to providers that are doing assessments, care and treatment? How do we police it?
If they're doing.
How do we know that they're not using, let's say an experimental drug or using a drug for an experimental off-label purpose if we're simply getting an invoice or however they bill us?
So I'm going to take a stab and then I'm going to look at my folks here to help me with that. When we get an invoice for a drug, it is likely through our POS system, right, or central pharmacy system.
Central pharmacy, or they could
Yeah,
bill individually,
or
but
they
we
bill
see the name of the drug.
Right. And so if we see a drug, now granted, we don't look critically at these items, but if Jenny or her team has a question about should we be paying for ketamine, for instance, then it bounces back to Elijah's team to do the deeper dive and investigation. We haven't had much need to do any of that. We haven't seen that, and quite frankly, I don't want to make it seem like, oh yeah, we just dive deep into the.
Right.
And the other thing is it would be rejected by Central Farm, because that's reimbursement model, so to speak, so we have to report on what drugs are being used where, and, you know, same with the jail prescription stuff that they're doing in the reimbursement program.
Is there anything that immediately comes to mind for you in our contracts with our providers that highlights this policy for us?
Other than the blanket statement that the providers will follow all board policies,
Okay,
um,
well, that's a strong one if they're committing to it and it's in our policy.
yeah. I wanna do a deeper dive into the actual contract language about this one in particular. My guess is there's something in there more than just, you know, a call, it's probably a call out.
Okay.
And, you know, the agencies themselves are policed more heavily by their certifying and credential bodies. We do I always call it a reconciliation, but it's not, it's a compliance review. But the majority of their compliance is really through CARF or JCO, or their recertifications from Ohio MHRSB, which are
Alright. Thank you.
Do we have a policy regarding funding agencies who are very unconventional and in terms of the way they treat patients and stuff like that?
we have a board-funded or eligibility for board treatment funding that would provide us some guidance on that. I don't know how I would identify it or describe an unconventional, other than we know what it is. You know, I don't want to go with the other, I don't want to use that example, but you know, things like evidence-based practice, right? Is built within our policy.
I just wondered, I just got to thinking if they had like this reason, just my
So-
brain, my imagination took over. for a
So
lot.
but our policy is just one item that guides agency actions, largely driven by their credential or their accrediting body, which is CARF or Joint Commission, which is much more stringent than what we are.
And includes a standard of care, right?
Always.
Yeah, so they have to follow the standard of care.
Always.
And I would think that would be one way we could look at it. If one of the agencies develops a standard of care for ketamine or other labeled, you know, drugs like that, that would be some persuasive evidence, I would think.
Yeah, for instance, our previous medical director was using ketamine to treat patients as our during our medical director. But he was doing it within his private practice. So you might have some docs working at community mental health centers that don't use it while they're at the agency, but do use it within their own private practice. Talking to the standard of care within the health center versus in a private practice.
Is there a motion to approve? Second, got it. Any questions, additional?
I feel like there's still a lot of wiggle room. I'm not saying this isn't a good policy. But I don't think it's actually good medication. I think it's easy to track. I think what's not easy to track is more the psychological therapies. Because I do agree that like CARF, Joint Commission has a lot of guidelines, but having the director of, well, you know, one, it's seen all of the Joint Commission, having gone through many Joint Commission reviews. And they do ask you a lot of questions, but still there's a lot of wiggle room. And what kind of therapies you provide to some extent. And then when you talk about therapies associated with the use of artificial intelligence, I'm not really even sure what that means, like where that wiggle room will end up being, you know what I mean? So I'm not sure what I'm saying, except for that I think it will be hard to track some of this. I think there will be a lot of things that we may have to ask questions about as things come in, or, you know, because we put a lot of trust in the community mental health centers, which we should, because they are the experts in what they do. But I think we'll have to also, just like with the ketamine, looking at what research is coming in about what is useful and what is not, like just be very aware of all that research.
I appreciate that, and we are open to any suggestions that you might have in a way to make this policy better. Understanding that we are not in the room during a therapy session, and there's 7,000 to 8,000 people that get funding for treatment services from this board, that we're never gonna know everything about it. We have to rely on the tools that are established. And also remember that there are licensing individual clinicians are licensed that have to also follow a scope of practice and standard of care as well. And while I agree that since you pointed out, if we wanted to make this a little more defined, we would define AI as, as it relates to the use of an avatar to provide those services versus in the background doing notes for the clinician, which we know of at least one agency that's doing that already. That's why I tried to scope it so that it would be direct service related as opposed to back office item. I'm open to.
Would it make sense if people look at it and say this is what it could be used for? Is that because it's smaller?
I
would
would
you know what
not
I'm
want to
trying
go there. Yeah, I don't know if we would have that time. Now, I will tell you, and I will own this one, is we are hamstrung by not having a medical director. Of that. I'll own that one. Maybe this is one of those things where if we had a medical director on contract, we would have better insight into how this policy might get deployed a little bit. But I have been reluctant to hire a medical director for lack of substantive work for that individual to do.
Could we have somebody that we can discuss and bounce ideas off and,
That's probably
or
the
we don't
best.
pay for, or deploy, engage, contract? Well, yeah,
Let's talk, okay,
on a one item at a time,
yeah.
like you would counsel.
Yeah, I mean, that's probably where we need to go. I mean, we have not had a medical director since, Dr. Yeshor left, which is 3 years ago now. And we have relied on, we have very good clinical practitioner here, so we've relied on Elijah and his insight. And it's always helpful if Dr. Alhai or Dr. Saddam before that would weigh in, and we talk to the agencies. But I do agree. And I think it might become more important as we think about what a benefit limits and utilization review look like. So that's where my head's going, but just to have somebody come in and spend time with us for anywhere between $250 an hour and $400 an hour was not a good use of board resources.
Even as a consultant.
They're hard to find.
Pardon me?
They're hard to find.
Yeah, hard to find that don't have a conflict. Yes, Jeff?
I'm assuming correctly that aversive conditioning would include conversion therapy.
That is not what we would assume as aversion therapy. I mean, the definition is to introduce to pair a negative stimuli with that behavior change that you want to see. So, for instance, alcohol and whatever the drug is that they give you that makes you nauseated if you drink. That's an element. As far as conversion therapy, if you're talking about sex change, Just, I wanna be clear,
No, no,
because
no,
I'm not,
somebody whose parents or family sends them to a mental health place to convert them from LGBTQIA+ to heterosexual conversion therapy.
Oh,
It's using the same thing, aversion therapy is used during the process.
so I've not heard it described like that, but I would say if there is an introduction of negative stimuli into that, because that's what aversion, the definition of
Yes.
aversion is, you know, electric shock with a certain behavior, or, you know, nausea, or, you know, introducing bad taste or negative smells or anything like that would fall into that.
So screaming in their face is a much lower level.
I'm not aware of any of our organizations that would do that.
You know, I'm just saying that I think that's, when you're saying that there has to be a physical reaction.
Let's remember, this policy only applies to our contracted agencies. Let's start there. So we do not have statutory authority to govern organizations or individual outside of our required catchment.
Just to keep it open, you do have it not including, not limited to, you know what I mean, which is good, because just in case someone slips into an agency with certain beliefs and they do that, at least then it's on here. You know what I mean?
Which would rapidly turn into a client rights issue.
Right, of
And your
course.
definition of aversive conditioning would include what I'm talking about, because that's how it's done.
Thank you.
So those are, those are definitions, standard definitions within the industry.
That's what I was able to come up with. Yes.
Okay. So understood terms of art is what I'm trying to think of within our industry. Okay.
All right, it's been properly moved in second. Any additional questions?
Yeah, I apologize for getting into the weeds, but I think the structure of the sentence is a little, doesn't really accomplish what you want, because including but not limited to really only modifies the hazardous procedures. I think what we're saying is we won't fund experimental therapies, experimental procedures, or hazardous procedures. Those are the three things we won't fund. And here are some examples of the things we won't fund that we're not limiting ourselves to.
All right, we can make those.
Yeah, I can help you.
Thank you.
Yeah.
You knew where I was going.
Set them off with Romanettes or something.
Yep.
And maybe you can, David, since you're gonna do some wordsmithing, address, what our true intention is with respect to artificial intelligence as well. Where, you know, use for minutes.
The direct use of artificial intelligence for
Treatment.
therapeutic purposes.
Yeah, perfect.
I'll shoot you the policy in Word. Remember to use the reviewer page.
Missing tonight.
It won't happen tonight.
No, good. We have another question.
So where would Vivitrol fall in?
It doesn't fall under this policy. That is a proven and effective strategy for.
Any additional questions? Those in favor?
Aye.
Opposed? Any abstentions? Motion passed. Moving on, we have item 10, 2025 first half year performance report.
Hi, good evening, everybody. I'm Julie Rook. I am the manager of quality and evaluation here at the board. So I have prepared our programmatic reporting information from the period January 1 to June 30th. Now, please keep in mind we were using the fiscal year 25 contract. So as we have been going through board meetings, the last couple of months, we've made some changes to some of our programs. So this report does not reflect a lot of the changes for the fiscal year 2026. This is fiscal year 2025 commission. So if you look in your report in your packet, you'll see that we kind of look at a larger scale of Lucas County information. For instance, like equitable access to behavioral health services. So for every 210 Lucas County residents, there is one mental health provider. So that is a good thing, because years ago we were at 300 to 1. Many more providers. Reduce suicide and unintentional drug overdose deaths. Unfortunately, our suicides have gone up, both adult and youth, within the last year, reporting year, so that would be the year of 2024. 2025 data has not been released yet. Everything that is in the report year with 2022, 2023 was the Lucas County Health Assessment, and that has not been updated, so those numbers have not changed since that report came out in 2023. I was able to find 2023 unintentional drug overdose deaths. 2024 has not been released yet. We were at a little elevated at 234. And of those 234, 212 were opioids. There were other drugs. I could not find the alcohol-related deaths. The Ohio information that the database, the Ohio database, did not include that. So, and they have been changing it throughout the last year, and hopefully they'll have some updates for us. Linkage to mental health services was at 57%, so that's the percent of homeless people, person 18 years and older with mental health problems who received mental health services. And then you can see exit to permanent housing is 120 days, which has gone up significantly. There is a hardship of housing out there. So then we're going to kind of take a deeper dive into our own funded agencies that the mental health board funds. So we fund 78 programs out of 25 agencies, and roughly 87% of our funded programs are on track to meet their goals for the calendar year. College. I had my original report, so it didn't have the board packet on it. And then you can see we broke it down into our three lines of business. So we provide treatment services, and 89% of our treatment programs are on track. Our prevention programs, 71% are on track, and then our supportive services are on track by 92%. And highlighted on the next page, so that is 3, are the programs that did not meet their quote-unquote goal. And you can, they are by line of business as well. So treatment, prevention services, and support. I'm sorry. Did you have a question? Okay.
show that TAS, Legal Aid, and UBIDOP did not meet their outcomes. One of them is the Opportunity Project. Is that for treatment or what is that for?
The Opportunity Project is treatment.
Legal Aid.
So we look at treatment because it's about connecting people to treatment.
What's your question again?
Well, I've checked the results with them, that's why I wanted.
They just didn't serve the number of people they had in facility because of some staffing issues.
Now they have another staff person,
So
so,
we don't expect that to be an issue.
okay, all right. Sorry.
That's okay. And then as you get to Appendix A, you can see each one of our programs are broken down. For instance, the first one is able government benefits. They're supposed to serve greater than or equal to 75, and they're currently at 34, which is about 45%. So we feel that they were on track because they had the opportunity to make up the requirements. And I'm happy to answer any questions you guys might have.
I do have a question for the treatment and prevention.
Sure, yes, I can explain. So when I begin this process, I send out emails with all of their information about a month in advance, and I ask for that to be returned. Unfortunately, UMADOP did not return their outcomes while I was preparing this report. They have submitted their outcomes, but their outcomes are Appendix B because I didn't get to put them timely into this report. They did not submit their information timely.
And we meet the deadline, is that what you're saying?
Yes.
So therefore, I assume there are no penalties associated with failure to comply in a timely manner or something like that.
That I might ask Scott for some little guidance on.
Remember, these were items from last fiscal year, many of which we would have addressed within the 120-day notice process. So this is after the fact reporting. So any issues that would have occurred during the reporting process were either addressed already or will be handled in our upcoming process as we are preparing for that now.
Your motion to approve? Commissioner Owens? Thank you.
Thank you. Thank you.
Thank you so much.
Thank you, Julie. Moving on to the next item, which will go annual report. Michael?
Thank you. Good afternoon. As some of you may remember, we have a whistleblower policy. However, even in the previous one, we had annual report on whistleblower activity, and there has been no whistleblower activity between June 1st, 2024 and May 31st, 2025. Thank you.
It's a good thing.
All right, open session. Richard?
On at One Government Center, I will be brief. Late item at the agenda review that I just came from Toledo Municipal Court is drowning in paper. I'm quoting here, "We cannot destroy old files fast enough." So this is on the fast track. It won't be put up for bids, but they'll spend $125,000 to ScanWorks LLC to scan old documents and then destroy them. And it'll hopefully free up some space within the next few months, but this is definitely on the fast track. Wish I could tell you more about Kratom. They had their public hearing a couple of weeks ago. They actually had a woman stand at the podium. She got down on her knees and she begged them not to outlaw this because it's used therapeutically for pain relief. Nothing really came of that. Now that we've got Governor DeWine talking about he's going to take action on this, at next week's city council meeting, they will simply refer it to committee where it can remain for a year before they have to do something with it, and they will wait for the governor to give them some kind of guidance on what they're going to do. But for right now, it's still legal, and the whole issue is, what do you do about the leaves versus these terrible derivative products? They're going to try and sort it out, but they're going to wait for the governor to give them some guidance. Last Thursday, 2-on-1 came before the Housing Committee. They gave a great statistical report about all the need here in Toledo. What they did not talk about and what the council members did not ask about, the $300,000 they were given a couple of years ago. This is ARPA monies. It runs out next June the 30th. It was desperately needed. There were 9 council members at this committee meeting. No one asked about it. I did. I asked during the open session. I reminded them of how important information and referral is. I reminded them in Detroit right now, they're choosing a new mayor because Mayor Dugan's going to run for governor. And they're all being asked about that terrible tragedy back in February where you had 2 children die of carbon monoxide poisoning living in a van. Just a few blocks away, there were empty shelter beds. But the mother did not know that. She was bounced from one agency to the next. The referral process completely broke down. These children did not die because of a lack of shelter beds. They died because of a lack of information. And we never want to let that happen here in Toledo. So that money runs out, and as you know, 2-on-1, they get all kinds of calls for everything from gambling addiction, mental health, substance abuse, housing. So if I'm making a suggestion, if they should come to this board and ask for your endorsement for state funding, I strongly suggest you give it to them because they're overwhelmed right now, and that's probably going to get a lot worse in the near future. September the 11th will be a very long plan commission. What is this? The Epilepsy Center of Northwest Ohio, which is located in Maumee, they're going to put a facility at 6048 Deer Park Court. I guess it's near Heather Downs. It will be for the developmentally disabled. It will be both job training and recreational activities. The Plan Commission is recommending approval of that. The big one is, what is this? Westgate Village North, which is located in Chicago. They will ask for their planned unit development for multiple commercial buildings. It's to develop the old Westgate where Sears used to be. 74 conditions. I think they'll have quite a bit of discussion. Then that will go before City Council Zoning and Planning on October the 15th. Hope to see that completed. And the one that really caught my attention, it's listed as 0 South Detroit. Well, it's going to be the new library. It's going to be right there, I guess, between the fire station and where the current state hospital is. Indulge me just for a moment. That is where they used to have what was known as the new receiving building. This was an old building constantly in need of repair. That's where individuals would be brought. At that time, a decision would be made. If they were compliant with medication and if they weren't violent, it's shipped right down the street to what was called the geriatric building. They call it geriatric even though there hadn't been geriatric patients there for years. That was where you had the chronic wards. And they weren't treated and released. They lived there at great expense to Ohio taxpayers. If they were violent, if they were the kind that would punch your lights out, well, they put them on the acute ward. The acute ward should have had a revolving door because that's what it was. Back then, you didn't have informed consent policies, so upon entering the acute ward, they medicate you. If you don't agree, they hold you down and they forcibly medicate you. Within a couple of days, you're sitting in a chair drooling on yourself. And they do that so that they can enter into the files that over the past couple of months, this person has not committed any violent acts, and then they release you directly to the Cherry Street Mission. That's what discharge planning was. Tell you which bus to take to reach the Cherry Street Mission. Once there, they either go off their meds or they mix them with drugs and alcohol, which is just as bad. Then they go out and commit crimes and the police bring them right back and the whole thing starts all over again. And so it was in 1988 that the state of Ohio said, enough already. We can't continue using these hospitals as housing for some patients and a Band-Aid for others. It's just not sustainable. And in 1988, with a 10-year implementation period, they passed that law. I believe it was House Bill 156. And millions of new dollars came into this board to support all of the people that we got out of that state hospital. And when I see these this is from Trump's first, this is September the 1st, 2019, Columbus Dispatch. After shooting, Trump fixed on mental institutions. He's still fixed on them. He's still, when I hear all of this at the federal level, I think to myself, we can't forget what mental institutions were. They were just a Band-Aid. So thank you for listening.
This Saturday, 11 to 1 at Friendship, right? Friendship Church. See everybody there.
Thank you.
Stand adjourned.